So we'll get started. I know we've had a lot of really great talks already, hearing about everything in thoracic and GI oncology. And so I'm going to go through a whirlwind of GU updates, both from ASCO GU and from ASCO annual meeting this year. So we're going to talk about some updates in bladder cancer, in both muscle invasive bladder cancer, metastatic urothelial cancer. We'll talk about LightSpark. I think that was the biggest data to come for kidney cancer this year. That was at ASCO GU. We'll, of course, talk about Proteus, which was the plenary at ASCO this year, and then touch briefly on two metastatic trials that were also presented. So diving into urothelial carcinoma. So first, I'm going to look at some of the muscle invasive bladder cancer data. We'll talk about Keynote B15 for cisplatin eligible, and then we'll also talk about the quality of life for Keynote 905. And then I'll dive into some metastatic data as well. So only a year ago, this was my slide, and it used to say the future, and now this is our new standard of care. So on the top of this diagram, you have the Keynote B15, which is neoadjuvant EV-pembro for 4 cycles for cisplatin eligible compared to chemotherapy. And on the bottom, you have Keynote 905 EV303, which is 3 cycles of neoadjuvant EV-pembro, which was FDA approved in December. And so it is crazy to think that a year ago, neither of these had been presented yet. And now really, it has really changed the paradigm of muscle invasive bladder cancer. So this is arguably the biggest data of 2026 in bladder cancer, Keynote 905, Keynote B15, which is EV-pembro in cisplatin eligible. And so these were patients that received EV-pembro compared to Gemcis. We, of course, have had Gemcis-Durva approved based on the Niagara trial also in this space. So this is comparing to a non-immunotherapy arm. And then also, we've had adjuvant immunotherapy around for many years at this point. And of note, a few patients in the control arm did receive adjuvant immunotherapy. So only 6% of patients received adjuvant immunotherapy, which became the standard of care in 2021. So I guess that's a caveat of the control arm here. And it was very much a positive trial. So it met its event-free survival with a hazard ratio of 0.53. And importantly, it also met its overall survival with a hazard ratio of 0.65. And then there was a difference of a path CR between EV-pembro and Gemcis of 55.8 versus 32.5%. And the side effects that we see with EV-pembro, we see a lot of derm toxicity. So I'm really excited for the next talk after mine, which is looking at how to manage derm toxicities related to all of our systemic therapies. So definitely stay for that talk. I think it's one of the most novel talks that we've had in a conference in a while, so it'll be really great. And then we also see that the surgery phase of EV-pembro versus chemo was actually pretty comparable. And then with EV-pembro, primarily for maybe trainees, the ones to really think about are skin reactions, peripheral neuropathy in a third of patients. We see a lot of dry eyes, ocular disorders, so we often have to refer patients to ophthalmology. Patients with an A1C over 8 were excluded from the trial, so we really have to watch for hyperglycemia, and we've had cases of DKA as a result. And so those are really the ones to look for. And then, of course, all of the immune-related adverse events that you see with pembrolizumab. So basically, it's not FDA approved, but is this a new standard of care in cisplatin-eligible muscle-invasive bladder cancer? A lot of people already think so. With the path CR being so high, can we preserve some of these bladders? So there are multiple trials right now looking at total systemic therapy where people are basically getting EV-pembro or other agents, and then they're basically having the option to preserve their bladders, not have radiation, not have a cystectomy, which is a huge quality of life metric. The other question is, this was a sandwich trial, so we don't really know, does everybody need the adjuvant portion? The way the trial was designed, we don't know the answer to that. And then what about patients with no response? They, let's say, had a T3 bladder cancer lesion, they get neoadjuvant therapy, and it's still a T3 at the time of surgery. You know, does it make sense to give people more EV-pembro in that setting? And then can we extrapolate from other trials, such as IMvigor, using ctDNA to avoid adjuvant treatment, to potentially extrapolate on who might benefit from adjuvant treatment the most? So we'll still have some unanswered questions in this space, but I think it's very exciting overall. We also most recently heard about the quality of life updates from Keynote 905. So same regimen, but this is in cisplatin ineligible. And the key takeaways here presented by Dr. O'Donnell, who is just down the street at the University of Chicago, is that basically the addition of EV pembro compared to cystectomy alone did not impair quality of life. So I think it's really important that more and more trials are reporting on quality of life for patients, because although we have more efficacious therapies, we also want to think about quality of life. And then finally, we heard about EV pembro updates. So we were talking about standing ovations earlier for pancreatic cancer. This was a standing ovation in 2024 for EV pembro, the 3.5-year follow-up. And I think it's helpful to know the updated data for these landmark trials, because we're recommending these regimens in clinic. And so what can we tell a patient in terms of what can you expect as far as your response long-term? And so basically, we see that the objective response rate with EV pembro is 67.5% compared to 44.2% with chemotherapy. And a third of patients achieve a CR. So it's the closest we're getting to a cure in metastatic bladder cancer. And at this point, we only have 3.5-year follow-up, but with longer term follow-up, maybe there are patients that have even longer term durable responses. The other thing we found out earlier this month is that among the patients who achieved a CR, there were many patients that converted from a PR to a CR, as you can see on the right-hand side. And those people had a similar 3.5-year survival. So even though if patients that don't have a CR immediately, having a PR converting to CR does show sort of that plateau on the curve, which is really exciting in terms of thinking about, are there patients that could be as close to cured for metastatic bladder cancer? And then for the treatment-related side effects, again, similarly, we think about neuropathy, skin reactions, hyperglycemia, dry eyes, and there were no new safety signals with the long-term 3.5 data. And then similarly for pembro, we see some of the most common immune-related adverse events, so hypothyroidism, pneumonitis, but no new signals here. And so basically, the conclusions by Dr. Powles is that there continue to be really exceptional responses with EV pembro. The cumulative responses, the third bullet point, deepened over time with particularly favorable outcomes in patients who achieved a CR. So this has been, presented at ESMO in 2024, and I have many patients in my clinic that I see that have had a CR, but they're either off therapy or continue on therapy and have undetectable disease since we started this treatment. So it's very exciting. And of course, we need to think about dose interruptions and reductions to continue this treatment. The other thing I want to talk about is HER2 therapy. So we've heard a lot in the prior two talks about precision oncology. And I think we are in the era of precision oncology in bladder cancer as well. And so this was presented at ASCO-GU. It's a phase 2 trial looking at disitamab vedotin in HER2 expressing previously treated advanced urothelial carcinoma. And here, compared to T-DXd trastuzumab deruxtecan, which has the pan-tumor approval, we are looking at HER2 positive and HER2 low in bladder cancer. And so similarly to breast cancer, we define HER2 low as IHC of 2+ with a negative FISH or IHC of 1+. And basically we see good responses whether patients were HER2 positive or HER2 low on the left and the right-hand side here. And we also see similar PFS and OS between the two cohorts. So, about 5.7 months PFS and then about 17 to 20 months OS across the two cohorts. Again, it was a phase 2 trial, so it wasn't compared to anything. And then as far as subsequent therapy, a minority of patients these were patients post-chemotherapy, so a minority of patients received EV. We would have obviously liked to see more people get EV because we know it's very efficacious. And the side effects that we see with DV, disitamab vedotin, a lot of fatigue and neuropathy, also based on the payload of this antibody-drug conjugate. So I think, in the US, we have TDX approved in the second-line setting of metastatic bladder cancer for IHC 3+ and actually recently this year 2+ as well. But we know that about 70% of bladder cancer have IHC of 1+. So, can we give more HER2 therapies to people that are considered HER2 low, the same that we do in breast cancer or other diseases? The other question is, this is a phase 2 trial post-chemo. How will this be relevant post-EV pembro? We just talked about the EV302, so that's really how we're treating patients. A small number got subsequent EV, so is this still going to be as efficacious? Will people have too much neuropathy and not be able to get agents like this? And then currently there is a phase 3 trial looking at DV pembro, and then the control arm is chemo avelumab. But how are we going to compare that? If it's a positive trial, people are going to say, well, the control arm isn't what we're using now. So, we'll probably have side-by-side data and sort of have to decide how do we want to approach those patients. So next, moving on to kidney cancer. And so renal cell carcinoma had very exciting data presented at ASCO GU earlier this year. We had the LIGHTSPARK 022 and the LIGHTSPARK 011. And so LIGHTSPARK 022 is adding belzutifan to pembrolizumab in resected clear cell RCC. And so here, the bottom arm is our control standard, which is what we've been giving now for a few years. So for people that have high risk resected clear cell RCC, as defined on the left-hand side, we give those patients a year of pembrolizumab. So here we're asking, would adding belzutifan also for a year improve the disease-free survival and the overall survival? Belzutifan, as a reminder, is a HIF-2 alpha inhibitor. And so some of the toxicities that we see here are hypoxia and anemia. And the baseline characteristics were well distributed between the two arms. And it met its disease-free survival endpoints with a hazard ratio of 0.72 with the addition of belzutifan. And across the subgroups also, many of the subgroups favored the addition of belzutifan. The overall survival results are immature and not significant at this point. And in terms of side effects, we see with belzutifan 42% grade 3 treatment-related side effects. So it's much higher than the 18% that we see with pembrolizumab. And then similar rates of immune-related adverse events as you would expect. And then, as I mentioned, belzutifan really has anemia as one of its most common dose-limiting toxicities. So we see 84% of patients with anemia. And then we also see a little bit more LFT abnormalities. Let's see. And then in terms of the anemia, I think it is important to note, how did people get their anemia treated? So 4.5% needed blood transfusions. That's not insignificant. 7% needed erythropoietin-stimulating agents, and then 1% needed both ESAs and blood transfusions. So I think when we're thinking, particularly in the adjuvant setting about patients that are potentially already cured, what is the risk benefit of adding something that could have significant toxicity? And then the other thing that is rate-limiting toxicity is hypoxia. So there was a small amount, but it's not insignificant. So 4.6% had grade 3 or more hypoxia, and 3% needed oxygen therapy. So these were the conclusions of the presenter, Dr. Choueiri, and belzutifan with pembro improved DFS. We need additional follow-up on the overall survival. The safety profile is manageable, but we know that there is not insignificant anemia and hypoxia. And so actually, hot off the press on Friday, this was FDA approved. So this is brand new. And so now the question is, what are we going to do here? So, now it's the 16th, 4 days ago, it's approved. We were already thinking we're probably over-treating a lot of people by adding all of this because some people are probably already cured. So could we consider it for the highest risk of this trial, the people that are M1 NED, so meaning they had oligometastatic disease, it was fully resected, those that have lymph node positive disease? What if the OS is negative? Will the FDA revoke this approval? And then we have other adjuvant trials in this space. So we have tivozanib, which is the STRIKE trial, which we have open at UIC right now. It's not 12 months of additional therapy, it's 6 months of a TKI. So how are we going to compare those trials side to side? And the discussant, when this was presented, said, and which I agree with, that it really has to be a shared decision with the patient. So you have a disease-free survival gain, you don't have an overall survival gain, there is additional toxicity and monitoring burden, so you really have to think about that. So the best fit would be for a patient that really wants to do anything to prioritize their disease-free survival and that doesn't have significant risk for anemia or hypoxia. And then even in the, in patients that are considered NED, no evidence of disease, the patient experience and quality of life has to come into the discussion. So hopefully we'll have more quality of life data for this as well in the years to come. And then right after, the LITESPARK-011 was presented, and this is belzutifan with lenvatinib versus cabozantinib in advanced renal cell carcinoma. And here, patients had to have received prior immunotherapy. So commonly in the frontline setting, we either do ipi-nivo or we do IO-TKI. And the question is, what to do in the second line. Most of the time, it's a single agent at that time. So here, you're adding another doublet, belzutifan lenvatinib versus cabozantinib at a 60 milligram dose. And one of the things I want to point out here in terms of number of prior VEGF TKI, so about half of the patients had been TKI, had received a TKI in the frontline setting. So about half you can assume maybe got ipi-nivo in the frontline setting. And it did meet its progression-free survival with a hazard ratio of 0.7. And not significant, but an OS trending towards the positive results, hazard ratio of 0.85. And then the side effects, actually the discussant said, surprisingly, if you were to remove the titles of both drugs, it looks pretty similar as far as she did a tornado plot. And you're like, well, actually, the side effects look sort of the same in both arms. But, we do know that there could be more hypoxia, more cardiac dysfunction. So at the bottom here, you see there is more hypoxia by adding belzutifan, 15.4%. More cardiac dysfunction, 7.0%. So it's not insignificant. I think we still have to screen patients, maybe think about cardiac comorbidities, think about pulmonary comorbidities when we're thinking about enrolling or about, giving patients this regimen. And so basically, it did meet its PFS overall response rate. The OS is favoring belzutifan lenvatinib, but it did not reach statistical significance, and it will be tested further at the final analysis. And the quality of life was similar between the two arms. And so it's a potential new treatment option. So is this a new doublet option after immunotherapy? It's not FDA approved at this time. We have another doublet, lenvatinib everolimus, which tends to be quite toxic, a lot of stomatitis. We saw the tornado plot is pretty similar. Is that going to be the same toxicity in the real world when we're thinking about non-trial patients that maybe are older, have more pulmonary and cardiac issues? And then what about the question of sequencing? How many people in the control arm got belzutifan sequentially? And then it would be interesting to know what the subgroup response was for people that got a TKI before as well. And then the discussant, Dr. Katie Beckerman, said patient selection, not escalation, is the challenge. There are some concerns here, patients with baseline anemia, patients with prior cardiac pulmonary comorbidities, or prior TKI tolerance. And so I think, for the right patient, it's a great option, of course, pending FDA approval, but we are moving the needle in terms of sequencing and RCC, which is exciting. And then finally, we will talk about prostate cancer. So we'll talk about Proteus, which of course was our plenary just 2 weeks ago, and then we'll touch on 2 trials in metastatic prostate cancer as well. And then I also think I included some on mCRPC as well. And so the Proteus study looked at perioperative apalutamide ADT versus placebo ADT with radical prostatectomy in high-risk localized or locally advanced prostate cancer. And so this is the trial design. So here, patients with high-risk prostate cancer were randomized to apalutamide for 6 months with ADT versus placebo ADT, and then the adjuvant was 6 months of APA ADT versus placebo ADT. One of the critiques was that the control arm is not our current standard. So I know Ahmad and I have talked about this in clinic, and currently people that are eligible for prostatectomy just go forward with prostatectomy. They don't get ADT before. They only get ADT after if they have high-risk features such as a positive margin or positive lymph nodes. And so the presenter, Dr. Mary Ellen Kaplan, said that the reason they choose a non-standard control arm is because they feared that by having a non-placebo, having a control arm that was basically just prostatectomy, that people would drop out and they wouldn't have long-term results and be able to really tell the difference of adding apalutamide or not. And so it did meet its dual primary endpoints of PATH-CR. So it was a 9-fold improvement in the PATH-CR after getting neoadjuvant apalutamide ADT, as well as a 20% reduction in the risk of metastasis or death. So hazard ratio of 0.8 for the addition of apalutamide. And so these were Dr. Kaplan's key takeaways: that it improves metastasis-free survival, improved major pathologic response, significant improvement in event-free survival, and delayed time to subsequent therapy, potentially setting the bar for a new standard of care. And so is this a new standard of care? We know that it is PATH-CR, metastasis-free survival. Metastasis-free survival in some analysis has been showed as a validated surrogate for overall survival in localized prostate cancer. It has a manageable safety profile. We know apalutamide increases the chance of rash, but generally well tolerated. As I mentioned, the comparator arm is not a current standard of care. We don't have OS data. I mean, that's really our gold standard. And also, one of the critiques, particularly from our radiation oncology colleagues, is a lot of times these patients with high-risk prostate cancer are really offered, do you want to have a prostatectomy or do you want to have radiation and 2 years of ADT? And we don't know the difference between those two. So now, if we're adding APA, ADT, is that better than radiation? What are the long-term outcomes? And then also, does everybody need this full sandwich approach? We also don't know the answers to that. The metastasis-free survival benefit is modest. It's 4.7%. And then actually there was a non-standard definition of high-risk prostate cancer. It was a biopsy-based definition for enrollment on this trial, which only 60% meet our NCCN high-risk criteria, which when we're in clinic, that's what we look at to sort of risk stratify patients. And although well tolerated, it does add it can add some extra toxicity. It is an extra pill. It's not insignificant for some patients. So next I'm going to talk about the ADREAM trial, which is a phase 2 trial looking at ADT therapy interruption in patients responding exceptionally well to androgen receptor pathway inhibitors in metastatic hormone-sensitive prostate cancer. And so this is the study design. So patients that had a PSA under 0.2 after 18 to 24 months of ADT and at least 12 months of an ARPI were given the option to stop all their therapy. And basically they had scans every 6 months. They had quality of life assessments. And then their testosterone was measured at 18 months. The characteristics, about 10.3% Black patients, majority white, non-Hispanic, Latino, and most patients were low volume that were enrolled here. And then as far as the testosterone recovery, about 41% had a testosterone recovery at 18 months. And then a third of patients at the 27-month follow-up were still not on treatment and still in remission from their metastatic prostate cancer. So the median duration off treatment was 24.5 months, so over 2 years. So it met its primary endpoint with 41% of patients remaining treatment-free with a testosterone recovery 18 months after ADT ARPI interruption. 38.5% of patients continue on treatment interruption at 26.9 months median follow-up. Only 1 of 4 deaths have been from prostate cancer. And so a treatment holiday in favorable responders is a reasonable consideration, and optimal intermittent strategies warrant further study. I want to point out that we have a trial that U of C, it's an IIT from University of Chicago, looking at men over the age of 70 that have been on 3 years or more of ADT. We're offering them the option to stop therapy and monitor if their PSA is undetectable. And, I think sort of going back to this, it's not ready for prime time. Again, this is a phase 2 trial. But I think there's a lot of interest for patients that we've been talking about this a lot in some of the other sessions. Like for some of these metastatic cancers, we're basically considering it a chronic disease. So we have to consider the lifestyle, quality of life for some of these patients that could potentially be as close to cure for metastatic cancer as possible. And so we know that a lot of the hormone side effects significantly impair quality of life. So can we do better for those patients? Could some of these patients maybe stop therapy and continue in a long-term remission? So a lot of work being done here. And then the other big study that was presented at ASCO earlier this month was TALAPRO-3. And so this is looking at talazoparib with enzalutamide in MCSPC in patients with HRR alterations. So again, precision oncology is moving across all cancers. In prostate cancer, we've had PARP inhibitors in the mCRPC state now for a few years. We had the AMPLO-2 trial presented last year, which was a positive study, and now we have TALAPRO-3. So we're moving a lot of our therapies earlier. And so TALAPRO-3 looked at talazoparib with enza versus placebo enza. And the primary endpoint was rPFS. They allowed not just BRCA, but HRR gene-altered MCSPC. And it met its PFS endpoint with a 52% reduction in the risk of progression or death, so a hazard ratio of 0.48. And then looking at the BRCA versus the non-BRCA subgroups, it actually was significant in both. So in the BRCA, you see the curves are way more separated on the left-hand side. We know that PARP inhibitors work very well for BRCA, particularly BRCA2. And then in the non-BRCA, we see some responses, it's still significant. So you have a hazard ratio of 0.36 on the left-hand side, hazard ratio of 0.56 on the non-BRCA group. So it's still significant, but we see the biggest effect for the BRCA group. And when you look at the gene analysis, we see that the ones that are clearly favoring the addition of PARP inhibitor are ATM, ATR. We see for BRCA2, very significant. We see for CDK12, very significant. For CHEK2, FANCA, we see more of a spread across the subgroups. CDK12 was a bit of a surprise for some people here because in some of the other PARP inhibitor trials, it had more of a mixed response with PARP inhibitors. And then one of the critiques always here is, the question of sequencing. So it's great to move things up front, but then if people on the control arm don't get access to the drug later on, is it just because they're getting access to the drug, or is it better truly to give it earlier on? And so here in the control arm, 27% of patients received olaparib upon progression, and all of these patients have HR alterations, so they're technically all eligible for PARP inhibitors. So that's one thing to note. So in conclusion for this trial, the PFS benefit was seen both in BRCA and non-BRCA. We don't have OS data yet. With enza being the partner here, we know that there's other data showing from the ARPIs that enzalutamide tends to be one of the ARPIs with the most fatigue and cognitive side effects. And then the toxicity, I didn't go through all the toxicity slides because my presentation would be too long, but 51% grade 3 anemia, again, not insignificant, including 2 treatment-related deaths, 3 cases of MDS, and 2 cases of AML. So for some of these MCSPC patients that potentially could have long-term responses, we want to be very wary of the long-term toxicity. Also, There was a small subgroup size, especially for the non-BRCA patients. There was underrepresentation of Black patients. And then the other question is, which is the same, there's no comparison to triplet therapy. So we know that we consider docetaxel for our high volume, high risk MCSPC. How does this compare to chemo for those patients? And then also, as of Friday, we have capivasertib, which is approved by the FDA.
All right. Hello, everyone. My name is Alwag Badash. I'm a dermatology resident. Today, we'll be talking about dermatologic toxicities of cancer therapies. And I thought to share with you a brief story just before we begin about a conversation I had with a friend of mine. At the time, she was 28 years old when she was diagnosed with triple negative breast cancer. And when we talked, I noticed that she wasn't afraid of dying. She wasn't afraid of not being cured. She had complete trust in her oncology team. But instead, she was so concerned and was so worried about how people will look at her, how she would function in society, how would her partner find her attractive, how she would feel in her own skin. And this discussion with her reminded me that this topic is beyond just side effect. It's part of patient advocacy. And with this in mind, the goals of this session is to recognize the many impact of skin and hair toxicity on patients' cancer journey. We will also identify and address common skin and hair toxicities associated with cancer treatment. I'm just going to share just a couple of slides, brief overview. So in terms of hair anatomy, we have three layers, the epidermis, dermis, and hypodermis. The main function of the hair is, of the skin is barrier. And there are lots of immune cells on the skin, and we will talk in length about immunotherapy. In addition, the turnover time for skin is about 28 days for healthy young adults, and it's lower as we age. As far as hair, so we have the hair shaft. It's above the skin. It contains the medulla, the cortex, which provides pigmentation and strength, and the cuticle. which is the outer layer. In addition, we also have the hair follicle, which is within the skin, and the hair bulb, which is the matrix cell proliferation that helps with cell proliferation. In terms of function, we have, so one of the most important functions is protection from UV or from trauma, but also hair plays an important social role. How people wear their hair is a form of self-expression, and in fact also sexual signaling. So pheromones trapped in the hair, and hair helps with diffusion of pheromones. As far as turnover time, we have three phases. Phase one is the anagen phase, where it's the growth phase. It's about 2 to 7 years. In fact, 85 to 90% of the hair on our scalp is in the anagen phase. Then we have the ketogen phase, which is a transition phase. It's about 2 to 3 weeks, and telogen, which is the resting phase, it's about 3 months. There are 100 to 150 hair on our scalp for most people, and it grows. And hair grows about 6 inches each year. We'll talk a lot about the anagen phase, just be ready. Again, dermatologic toxicities are beyond cosmetics. It's very, very common. It's very visible. It's almost outward sign of the disease, which has psychosocial impact, increases anxiety and stigma and depression, affect quality of life and self-image and self-worth. It has high burden. A lot of the dermatologic toxicities that we'll talk about cause a lot of itching, and it's quite painful. And taking it all together, it has impact on the overall treatment. In fact, there is a report that showed that 17% of patients reported that skin and hair toxicities as the most traumatic adverse effect, with 30% saying it was extremely limited, and 14% of patients said that refuse curative treatment due to the skin and hair toxicities. All right, so we are going to dive right into cytotoxic chemotherapy-induced alopecia. Chemotherapy primarily causes anagen effluvium by targeting rapidly dividing hair matrix cells. And because most of our scalp, as I mentioned earlier, the hair scalp is in the anagen phase, hair loss is very rapid and very diffused. And again, there are the two other phases that stays, which explains why even, especially initially in the worst case of alopecia due to chemo, you still see some hair. Importantly, the follicular hair stem cell is still preserved, which explains why hair regrowth after the completion of chemotherapy. Here, you can, do you see my point? Oh, you don't. Okay. So on the right side, we see, is there a pointer? No, I guess. On the right side, we can see where chemotherapy affects the hair in the hair matrix cells. And here on the right side, we can also see pictures of alopecia throughout chemotherapy. This all changed in 2017 when the FDA approved the cooling cap. So in a randomized clinical trial of 182 women with breast cancer receiving chemotherapy either with taxane or anthracycline or both, those who underwent skull cooling were significantly more likely to have less than 50% hair loss compared to the control group. In fact, the study was so successful that they stopped the study much earlier. And another point that I want to talk about is a little bit about terminology. So alopecia grade 0 and 1 is essentially hair loss that is less than 50%. And alopecia grade 2, which is considered failure, is hair loss that is greater than 50%. And if you're asking why 50%, is because it's believed that people notice hair loss when it's greater than 50%. And because this is a dermatology lecture, we're going to look at many images. On the left side, we can see patients before with cooling cap and control. We see them before treatment and a month after treatment. And in the control, you can appreciate 1 month after treatment how it looks like. In the cool hair trial, I took those pictures from. You can see that patient A, B, C, and C received the cooling cap. Patient D is the control. You can appreciate that patient A and B were able to preserve their hair, or most of the hair, with the cooling cap. Patient C, it was not a success, it was alopecia grade 2. And we'll talk about some of the limitation of the cooling cap. So how does it work? Scalp cooling is thought to protect the hair follicle through 2 main mechanisms. And first and most established one is, or theory, is that cooling induces vasoconstrictions, which reduces blood flow and limits the amount of chemotherapy reaching to the scalp and the hair follicle. The second theory is that cooling decreases the follicular metabolic activity and making the hair cell matrix keratinocytes less susceptible to chemotherapy-induced damage. So those are the main 2. There is another very interesting theory, it's not included here, which is essentially that the cooling cap stop the activation of the apoptotic signaling activation. There is a study that shows that patients that were wearing the cooling cap had 50%, they had less hair loss throughout their body and not just their head, compared to patients in the control group, which is where this theory came to life. Interestingly, or unfortunately, this was not significant, which is also why it's not on our slides. So cooling caps. So it overall improved the quality of life, decreases the distress associated with alopecia. It has minimal to no side effects. And when it comes to hair and scalp care between treatment, the main idea is to avoid excessive heat and excessive pressure. And this is quite challenging for patients. We are asking them essentially to wash their head once a week. It's not very easy for people that tend to do it more often. And even with them, asking them to not brush their head because of the excessive pressure. So this is quite challenging, especially when you are asking patients to do it for several weeks or even months. In terms of timing, taxane-based regimen have shown to have higher success in preservation of hair compared to anthracycline. And we're also asking patients to come about 10 to 30 minutes before infusion, before the chemotherapy infusion, and having the cap throughout the infusion, and then post-infusion to stay in clinic about 30 minutes to 150 minutes after the infusion. Above anything beyond 150 minutes is actually considered toxic, and now there are more studies that are showing that there's no much need to have 150 minutes. In fact, you can do it much faster. Let's talk about some limitations. The main one is cost, and it's not as accessible. It's estimated to be $1,200 to $1,800, which is quite expensive. I wanted to share with you an organization called Hair to Stay. This organization is essentially helping patients to pay for the cooling cap. In terms of legislation, New York State, as of 2026, is the only state where it requires certain health insurance policies to cover scalp cooling systems for the preservation of hair during cancer treatment. Again, we were talking about patient advocacy. This is definitely a way that we should have more states cover the cooling cap. Other limitations. So again, as I mentioned in the previous slide, it's quite hard to adhere in terms of treatment between the cooling caps. In terms of proper fit, so the cap needs to be really tight on the scalp and change, like the hair texture, the volume of the hair may affect the success rate, again, dosage and the type of chemotherapy as well. In terms of racial disparities, there are minimal to no high quality data on Black female patients. In fact, I'm going to mention only one that I found, a case report. So as I mentioned, minimal success in Black female patients, and the thought is because the cap should be really tight on the patient's head, and it's harder to achieve success when the hair is a little curled or tightly or has more volume. There is a very interesting ongoing study at Montefiore Einstein Cancer Center where they are doing clinical trial where they use different techniques to prepare the hair before the initiation of the cap. So hopefully, and next year when we talk, hopefully we'll use it as an example of success rate in Black female patients. Here I wanted to show you one case report of skull cooling success in Black women. On the left side, we can see her hair at baseline before treatment. In the middle, we see immediately after the last round of chemotherapy. Here they called it success as less than 50% hair loss. I personally can appreciate the hair loss, but still success. And on the right side is 5 months after chemotherapy. We'll talk a little bit about alopecia persistent after chemotherapy. So persistent chemotherapy alopecia is a non-scarring alopecia, persistent more than 6 months after the completion of chemotherapy. And endocrine therapy-induced alopecia after chemotherapy, this is alopecia that occurs after completion of hair regrowth from post-chemotherapy, and we can clearly say that that was due to treatment from endocrine therapy. And as we know, estrogen is a big driver of hair growth, and with the absence of estrogen, it is harder to recover. When we think about some of the causes, definitely some risk factor would be the chemotherapy type, the higher doses of chemotherapy, advanced age, as I mentioned, and also combination of chemotherapy. And here on the right, you can see several combination of chemotherapy. When we talk about management, first line is topical minoxidil or oral minoxidil. Second line is oral Spiro, either alone or with combination of topical minoxidil. I'll talk more about those. In terms of prevention, is interesting because scalp cooling shown to have a success in prevention as well. So here's a study that shows that the effect of scalp cooling on persistent chemotherapy-induced alopecia at a 6 months visit. And as we can see here, those that had a cap had 13.5% had persistent chemotherapy-induced alopecia versus control that didn't have the cap, which was 52%. So this is quite significant. Some of the therapies to avoid in specifically hormone-sensitive breast cancer is finasteride. So as I mentioned, we wanted to talk about management. The first one is topical minoxidil, 2% to 5%. I personally would just go with 5%. This is FDA approved. Here's an interesting study that showed that topical minoxidil that shortened the alopecic period from 137 days to 87 days. So this is quite significant, and I would definitely encourage everybody to encourage their patients to use it. Oral minoxidil, we would titrate it up from 125% to 125 milligrams to 5 milligrams daily. This is off-label for androgenic alopecia. Spiro, as I mentioned earlier, it's 200 milligrams daily, again, off-label for both androgenic alopecia and persistent chemo-induced alopecia. And finasteride, which is a 5-alpha reductase inhibitor, again, off-label, but not for hormone-sensitive breast cancer. I wanted to show you the hair metric here, over there on the which is quite interesting. This is, of course, AI, because everything nowadays is AI. This is another tool to track hair regrowth. I'm not sure what we have to do with it in practice, but it's definitely helpful for research purposes. This is a very cool study. So this study showed the long-term safety and efficacy of bimatropus solution of 0.03 application to the eyelid margin for the treatment of idiopathic and chemo-induced eyelashes hypertrichosis. Again, this is a randomized control trial. And as we can see here, starting on the left side, there is quite significant at the 6 months mark of overall improvement of the eyelash from 46.90% for patients that got the solution versus 18.2%. And when we look at the eyelashes characteristics, thickness increased by 200 and almost 250%, and overall increase in length and darkness. And I wanted to create this slide for you that will help kind of use it as a visual presentation. So you use the solution, and it's the solution is a prostaglandin analog, which binds to the prostaglandin receptor on the hair, and by doing so, it helps again with pigmentation and thickness and prolonging the anagen phase of the eyelashes. And again, this is FDA approved. Here on the right side, what you see between is from the study that I mentioned. From the study that I mentioned, you see the 6 months with the solution versus the one with vehicle, which is essentially the control group. So this is quite significant. Again, something to recommend patients. This is FDA approved. I'm going to end the talk about hair before we move to the skin with some of the recent research efforts that focuses mainly on improving the preservation of hair. One interesting study is a topical agent, DA020, which is alpha agonist that's currently being evaluated in a clinical trial. It's essentially designed to cause vasoconstriction to the scalp and essentially work as the scalp cooling device. Another interesting study from Michigan State University, they developed hydrogel, which almost uses a shampoo for the hair and scalp. And again, to cause a chemical or pharmaceutical chemical scalp cooling effect. And if this is successful, it's essentially much easier to use for patients. And again, the study I mentioned of patients of color with the preparing the hair before initiation of the cap. Okay, so now we'll talk a little bit about skin toxicities of cancer therapies. The skin is a collateral damage in the war of cancer, either scar formation from surgery, chronic inflammation from radiation, or autoimmune diseases from medical treatment. We'll start our discussion on radiation-induced skin toxicity. So in terms of timeline, we have short term. So now we're talking just about radiation. We have short term, which is days to month. Acute radiation dermatitis is usually within 90 days. It's very common. Then we go to the medium term, which is months to years. It's likely to be irreversible, and it's over 90 days after the end of treatment. And usually you would see chronic skin changes. For example, epidermal thickness, dermis atrophy, keratinization, skin fibrosis, and vascular injuries. Then we have long-term, which can arise decades after, which is usually secondary malignancy. So the National Cancer Institute has developed four classification for the acute radiation dermatitis. The grade 1 is faint erythema or desquamation. It's very common in darker skin tone. It has long-lasting effect, and it's quite disfiguring. Grade 2 is moderate to brisk erythema. You would appreciate moist desquamation, and you would also see moderate swelling. Grade 3 is moist discrimination that is greater than 1.5 centimeter in diameter, which is not confined just to the skin folds and has pitting edema. And grade 4, which is this picture on the right, in grade 4, you see skin necrosis or ulceration of the full thickness dermis. Most common cutaneous toxicities often go underdiagnosed in darker skin tone. So what we think about red, it may in darker skin tone look more brown, violaceous, or hyperpigmented changes. Unfortunately, because it goes underdiagnosed, it's also patients are undertreated. So we are going to talk a little bit about chronic radiation skin toxicities. And again, most of these chronic radiation skin toxicities, as I mentioned before, are irreversible. And here I try to explain it with this image right here. So in terms of the mechanism of action, you have the ionizing radiation that attacks the DNA of the cell through the formation of free radicals, which damages the DNA double strand and make the normal cell mitosis being essentially does not work as well. Radiation may also damage the skin appendages such as sweat gland, sebaceous gland, hair follicle, and the basement membrane. And this by itself weakens the skin, and that's the main issue. Post-inflammatory hyperpigmentation, this is quite important and quite significant, especially with darker skin tone. There are two pathophysiology, two mechanisms. The first one is pigment incontinence. Essentially, the damage to the keratinocytes releases melanin, which has been taken by the macrophages. However, it takes years to clear those macrophages. The second one is essentially that inflammation increases the overall melanin production. So we'll talk a little bit about prevention. So prevention of acute radiation dermatitis focuses on reducing inflammation and modifying contributing factors such as skin microbiome. One of the most established ways to do so is topical corticosteroids. And here is a study that showed the use of mometasone, which is the recommended agent, compared to Eucerin cream. And when patients are using it, in this study, they measured the grade 2 of moist discrimination or grade 3, and we can see that those with mometasone only had 28% developed grade 2 or grade 3 versus 40% that used Eucerin. So this is quite significant. Another emerging approach is bacterial decolonization. We know that colonizing organism, particularly Staph aureus, can worsen inflammatory skin conditions. And in radiation patients, when we lower the microbial diversity, it's definitely worsened the overall, worsened the dermatitis. So this is a study on the right that we can see that focuses on decolonization protocol that typically include intranasal mupirocin ointment twice daily, as well as chlorhexidine cleanser and once daily. And they did it 5 days before radiation therapy and then repeated for 5 days every 2 weeks through radiation therapy. And as we can see here, none of the patients with bacterial decolonization protocol that use that compared to standard of care develop grade 2 or higher skin toxicities. But this is, again, it's emerging, it's very new, very exciting area, still requires lots of more prospective studies. I'm going back to topical steroids for 2 more slides. So the multinational associations of supportive care in cancer, they released a statement that essentially supports the use of topical steroids. So they recommend topical steroids for the prevention and treatment for acute radiation dermatitis. In terms of how to use it as early as possible. So you use it from the very first day and use it every day, either once or twice to affected area. The preferred agent, as I mentioned before, is mometasone. You can also use triamcinolone. In terms of benefits, again, it's the decrease of the severity of the acute dermatitis. Also decrease erythema, pruritus, and discomfort. And by doing all of that, you also decrease the grades of the dermatitis. In terms of safety, it's generally well tolerated. There are no consistent evidence of increased infection, which is something that we would worry about, and no significant skin atrophy, especially when used short term, which is important to emphasize the short term part. This is a brochure they have for patients. Again, we can print it in clinic and give it to our patients. And I want to talk about very interesting treatment with the use of hydrogel dressing, which are widely used in radiation dermatitis, particularly for patients with moist desquamation. The main idea is to create a moist environment, reduce the pain and discomfort. But again, they're widely used in there's no one particular protocol in this area. But there is very interesting ongoing studies and trials that try to use it as a personalized and focuses on the multifunction of the hydrogel gel. So for example, the smart hydrogels, which has sensors that sense the pH and the temperature and would respond and release the substance from the gel. There is another very interesting idea of using antioxidants or even antimicrobial drugs in the hydrogen gel. This is an exciting area. Again, all of these are quite new, but I believe next year we'll talk and have very more information. All right. If we can, we're going to move on to the last portion, which is medication-induced skin toxicity. We'll focus on chemotherapy, targeted therapy, and immunotherapy. So this is from ASCO. These are all the chemotherapy agents and the different skin toxicities. As you can see, there are plenty. I will mention a few, but hyperpigmentation is a big one. Type 1 hypersensitivity reaction. Of course, alopecia and hand-foot syndrome is another one. So as we can see here, again, this is dermatology lecture. We'll see lots of pictures. Hand-foot syndrome. We can look at the bilateral hands that we can appreciate the hyperpigmentation and the scale and hyperkeratosis of this patient. All used chemotherapy. In the middle, we see a erythematous patch and hyperpigmentation of the face and in fact also the tongue. I don't know if you can see it from your point of view. In terms of targeted therapy, and of course, we have the EGFR inhibitors. I will talk in length about them, which cause papulopustular eruption, acneiform rash, cirrhosis, fissures. Also, morbilliform rash is quite significant form of targeted therapy. Here, just a few examples. On the right side, we see hand and foot skin reaction. We can see the acneiform rash. Again, acneiform is not acne, treated differently, so it's important to recognize that, and papulopustular eruption. When we talk about immunotherapy, as I mentioned earlier, there are tons of immune cells on the skin, and cutaneous immune-related adverse events are very, very common and very severe. And we can see them in the immune checkpoint inhibitors. We can appreciate the maculopapular rash, pruritus, eczematous rash, lichenoid reaction, and different autoimmune skin conditions. And here are just more pictures of bullous pemphigoid. In fact, I had a patient last week that had bullous from chemotherapy. From immunotherapy. We also see here the lichenoid reaction and the maculopapular rash. So a good rule of thumb, I would say, is that when we see something, if it's an eczema, for instance, we want to treat it for eczema, regardless if it's from secondary to chemotherapy, immunotherapy, etc. This is just a good rule of thumb. So we'll mention a few presentation and first line, first being cirrhosis. We can see the scale and dry skin and hyperpigmentation. You can definitely suggest moisturizer, over-the-counter anti-itch cream, and topical steroids, specifically triamcinolone 0.1%. When we look at the more beautiful rash, this is very, very itchy, and you can see the pink and patchy and bumps, and usually it's self-resolved, but you can help with topical steroids. This is a form of psoriasis. We can look at the pink scale raised lesions. Here, in this case, I would refer to a dermatologist. And again, when mainly it's topical steroids used, but phototherapy, systemic agents, this is where derm and onc should discuss and collaborate. Bullous and blistering diseases, again, the first line is steroids or triamcinolone or prednisone, 0.5 to 1 milligrams per kilogram daily, and rituximab, which has been quite established as well, one of the helpful agents to use. Again, it's very itchy. So I'll start with some of emerging therapies. But before we get to that, systemic corticosteroids remain the most common and first-line treatment for cutaneous immune-related adverse effects. But unfortunately, sometimes patients cannot use corticosteroids for different reasons. One concern could be the immunosuppression and the impairment of the anti-tumor immunity in patients that receive cancer treatment or immunotherapy, and patient might be having refractory to steroids. Hence, we have steroid-sparing agents like what we know nowadays, Dupixent or dupilumab. This is a systemic review that goes over Dupixent, but in general, dupilumab targets the IL-4 and IL-13 pathway, which are key mediators in the type 2 inflammation, which implicated as mainly affect the pruritus and eczematous rash, and this is very helpful, and I think I talked to Dr. Tawaji last week about, she told me that she has a patient that is on dupilumab. So that's very exciting, especially that we use it here at UIC. Here again from the study, the bottom line here is that dupilumab is very, very effective and well tolerated for the cutaneous immune adverse events, particularly when we think about eczematous rash or bullous phenotypes. But reassurance is still needed, so we need more studies that mainly focuses on the oncology safety of dupilumab. There are very sporadic studies that I found not showing causality, but show some association with either unmasking or progressing of cutaneous T-cell lymphoma. All right, I promised to talk about EGFR inhibitors. So EGFR inhibitors commonly cause a cuneiform rash, as I showed before. And because because EGFR signaling is very important for the tumor, but also very important for normal skin. So it's so common that it's more than 70% that patients that are using EGFR inhibitors that would develop some rash or cuneiform rash. In terms of pathophysiology, when the EGFR is being blocked, keratinocyte function is being disrupted, which leads to inflammation in these characteristics of the rash. Interestingly, BRAF inhibitors has paradoxical effect on the reactivation of the downstream signaling of the EGFR. And based on this theory, there is a very interesting study that developed BRAF inhibitor that is topical BRAF inhibitors that essentially being applied that patients are using. And we'll talk about it here. Perfect. So this is a phase 2 trial that evaluated the topical LUT-014 in patients with colorectal cancer who developed moderate to severe acneiform rash. So again, those are the grades. So we can see it grade 3 and 4 from the EGFR inhibitors. And these, in this case, patients were randomized to two different concentration of the gel and placebo, and they used it daily for 28 days. In terms of primary outcome, the main goal was improvement of at least one grade, so grade 4 to 3 or grade 4 to 2, or improvement in 5 different quality of life measures. And as we can see here, on the success rate, there is quite success with the 0.1 formulation. And this is very exciting. This is right now on phase 2. Okay, last trial that I'll talk about. It's the Cocoon trial. Here is another study that focuses on EGFR inhibitors and skin toxicities. This is a more proactive approach. So here, patients were randomized to either the Cocoon dermatologic management program or the standard of care. And when we think about prophylactic regimen, they're talking about oral doxycycline or minocycline, topical clindamycin 1% for the scalp, and chlorhexidine 4% for the nail, and ceramide-based moisturizer daily. And the standard of care is essentially no proactive approach in terms of treatment. And the primary endpoint for them was the incidence of grade 2 or higher of dermatologic adverse events of their own interests. And I want to start, so these are the results after 12 weeks. Let's focus first on the one in the middle, where you remove the nail toxicities. And we can see that in this case, after 12 weeks of just using very simple regimen, prophylactic regimen, patients only 27% develop grade 2 or higher of skin toxicities versus 62% of patients. And again, this is quite significant. On the left side, we see grade 2 or higher as a primary endpoint, including the nail toxicities. Again, 42% versus 75%. And after 6 months, it's 41% of patients that had skin toxicities versus 76% of patients. This is quite significant, especially knowing that patients use a very simple regimen. Again, let me show you: oral doxy or minocycline, topical clindamycin 1%, chlorhexidine, and ceramide-based moisturizer. Okay, last slide is a case. I will let you read it on your own. But the main question is, which of the following statements about scalp cooling for prevention of chemotherapy-induced alopecia is accurate? I'll give you 30 seconds. Okay, can I? All right. The answer is B. Scalp cooling system reduces the chemo-induced alopecia by inducing cutaneous vasoconstriction, reducing the follicular uptake of chemotherapy agent, and by doing so, preserving the hair. And this is another picture of the scalp cooling device. All right, let's conclude this talk. Dermatologic toxicities are among the most common adverse effects of cancer therapies and can significantly impact patients' quality of life, self-worth, and self-image. Skin and hair toxicities truly have psychosocial impact, as I mentioned, and these toxicities affect changes between the classes. So we need to know the mechanism of action to help patients. Now there's a lot of effort when it comes to being more proactive rather than reactive by using prophylactic treatments. And this is where things are heading. And that's, to me, the take-home message. And thank you so much. I appreciate it.